Yeah, of course. So, hi, I'm Adam Townsend. I'm one of the founders of VUIT. We are a data company. We specialize in the ingestion and manipulation and visualization of what is predominantly population health data. So I am going to share my screen. I don't know which screen I'm going to share. That could be a challenge, right? Entire screen. There we go. Am I presenting what you would like to be able to see?
Yes, well, you are. Yeah, sorry.
Perfect. Right. Okay. Well, thank you for having me. It's so inspiring listening to the conversations and the presentations earlier, and some real gems for me. I'm hoping by the end the title of this will make sense. I'm just going to tell a few stories with a few pictures. So our passion is big data and what it's capable of. I use the word passion very selectively. There is an argument that the big data movement is about, something that's our ability to show off by being very, very technical, and we don't sign up to that view of what big data should be about. This is our view. It's very practical. Actually, big data is only useful when it's put into harness, and typically when it's used in conjunction with other big data and combined. And there was a conversation earlier around, how do you make that data interoperable? And there's a lovely saying that goes along with this visualization. So yeah, we're probably a good stupid horse. Why do we exist? So over 10 years we've been combining data, and we've been using this slide for all of those 10 years. This is what our passion drives us to, and without doubt the ability and need to generate better pharmaceutical solutions is very real as the population ages. But equally, when 75 to 80% of our health and well-being outcomes are driven by non-health factors, and there was in one of the presentations earlier, and I'll reference this a little bit later, there was a product that addresses black mold in houses. So we're very much about understanding the wider life experiences and wider determinants that a population is understanding at a hyper local level. So taking that data, overlay, making it interoperable, making it longitudinal, and then taking it down to very small geographies to understand where we can deliver interventions specifically, rather than, as Steve said, some of these things are just too expensive to deploy across everybody. But if all you can see is everybody and all you've got is data on what the average person, there's no ability to deploy these interventions precisely. So that precision delivery of interventions into populations is what we're about. People say, can we look at your data? So there it is. This is a visualization of our SQL server. We've got views and tables in there that are all interoperable with each other. We think we've got about 29 billion interoperable data points. This is what's in there, a sample of what's in there. So everything that is in our data set is fully GDPR compliant, fully available to be used commercially, and is government standard for redaction and consolidation. And we bring it together and make it, as we said, interoperable and longitudinal. But we have everything from Food Standards Agency data, crime data, charities, a lot of the health data that you'd expect to see, care home data, provider data. we bring all of that together, education data, things like adherence to medical regimes. Well, education, skills and training deprivation is going to tell you where actually some people are going to find it really hard to adhere to their medical regimes because actually their literacy and numeracy doesn't support them to read complex labels. So that's just a really quick example. So that's what we have. That's what we serve our customers with. I'm going to touch briefly on AI. We are putting an AI layer, a large language, and a Gen AI layer in. There are two reasons for that. The visualizations I'm going to show you shortly are the ones that our customers have asked us to develop and deliver to them over time. They answer thousands of questions because they're very configurable. But we know that there's the opportunity to answer millions of questions. And the only way we can do that is to allow people with more specific questions than we would have, or more intelligent questions that we could think of, because we are not experts in all of these landscapes. Giving people the ability to do that is really fundamental to getting the most out of leveraging the most out of the data that we've brought together. The second reason is a commercial one. We know that once we built that landscape in a large language model Gen AI framework, we will be able to ingest data across multiple countries without having to reimagine it. So we can tag it into the Gen AI, and we will be able to interrogate it because the AI will understand that data in context because of what we've taught it about the landscape we've got in the UK. So the ability to go multinational and certainly, move into America is very much our next step. And we know that most of the data that we're showing you here actually exists in the US, and we could ingest it and launch minimum viable product very quickly. And it's just a couple of quotes here, in terms of how it might help to support redefining clinical trials, and our big ambition: could we get a health and wellbeing digital twin of England? I'm going to focus in now, the title, an aging population. I just want to kind of stand that on its head and put forward a thought that we might be looking at it through the wrong end of the telescope. And again, there was a comment earlier about the fact that historically there are enough working age people to generate enough tax to pay the pensions of the older people, and that is not the case. But that's not just a product of people getting older in pure numbers. It's a product of there being massive swathes of England and the UK where people of working age are not able to work because their long-term conditions and their health and well-being prevents them. So we've got the sick working age person looking at the old person who is becoming increasingly old because their ability to keep people alive is increasing. So I just want to sort of take the opportunity in this presentation to just, as I say, look at it through the other end of the telescope. Why do I think it's important? So this is the first of these are visualizations from our tool. This is a graph that shows life expectancy versus healthy life expectancy. And over here, we've got Manchester, who have a life expectancy of 79 years and 61 years of healthy life expectancy. So an 18.4 year gap. And Surrey Heartlands, which is Surrey is adjacent to London for people in the call that aren't UK based. Very, very rich area. Life expectancy is significantly higher, and healthy life expectancy is 3.9 years longer. There are 4 million people in Manchester. There are 1.1 million people in Surrey Heartlands. The rough maths says that ultimately, if we take those 2.9 more people and 3.9 less healthy years, there is an 11.4 million healthy year opportunity in one ICS, intermediate care service. These are the geographies that the UK splits itself into for healthcare. They run at about 1 to 1.5 million typically. But yeah, just wanted to frame that, so this is very much about that healthy years opportunity, and that our age versus our and there was a really good presentation about what's my heart age, what's my physical age, my activity and flexibility age. Fundamentally, healthy years is it's the same objective whether you are 80 or 48. That these are the years that we should be supporting people to have. These are the years that if we can improve, will actually reduce that significant burden. Partly because more people will be able to work, but partly because people, as they approach older age, will be healthy, will be living healthy years and not unhealthy ones. So again, visualizations of this is a part of the West Midlands, just to the west of Birmingham or northwest of Birmingham. I just wanted to flick through some of this and see what we can start to see. These little coloured patches are called lower super output areas. This is the lowest currency that we can measure a population in with government issued data. Typically about 2,000 people in a town. That could equate to 2 or 3 streets. Obviously, in rural areas, they're bigger footprints. But we can know a lot about each of these LSOAs. And here, for example, this is a heat map of where our over 75s live. So there's a little place called Aldridge up here. And this is our number of long-term conditions per patient. And it's like, well, this is not a very surprising visual. That actually, where we've got older people, we've got high long-term conditions. Actually, what I've changed that to now is to cancer prevalence in this same footprint. So we can see where our aging population is, and we can see where our cancer prevalence is. And it overlays almost perfectly. So if we look back a slide and talk about the average long-term condition burden in our population, we can see that most of our long-term condition burden lies with our over 75s. But when we start to exclude cancer, which realistically is it affects more people as they age, and we start to look where cancer is less prevalent, we can understand that in these populations where over 75s are less prevalent, there's a pretty good reason for that, and that is because the deprivation, the wider determinants, and the long-term condition prevalence of other things that will kill you is much higher. So now we're looking at diabetes versus the over 75 population. And immediately we can see that our diabetes prevalence is not residing where our older population is. So actually, if we want to support and prevent diabetes, prevent diabetic exacerbations, work with people who are at risk of diabetes, and we can show this for obesity as well, which paints a very different picture. But fundamentally, the message here is that the association between healthy years and or supporting an aging population using the number of years it's been on the planet versus an individual's march towards death, be that earlier or later in number of years, it just, I think, raises a question of, are we using the right currency when we talk about the aging population? And I think we just need to be careful about that. Talked about this earlier. So here again, sticking with the over 75s, this is a subset now. This is a local authority within that footprint I showed you earlier. So this is Sandwell. I like picking this one because it looks like a woolly mammoth. It's got its legs and its trunk. So here we're looking at deprivation. And again, we can see that where our deprivation isn't quite so bad, our population is older. So this is where we start to understand the wider determinants are at play. So education, skills and training, crime deprivation, income deprivation are very, very closely correlated to these long-term conditions that will be limiting healthy years. And then I've just picked one of the little LSO areas that I talked about just to show you So for every one of these LSOAs, we have a raft of information that we can layer because it's interoperable, because it's longitudinal. And this is just a bigger version of the visual to the right. So, just as a snapshot of what's in that little area, there are 3,300 people in there. This is the percent that's over 75 versus 0 to 16. So actually, we know this has got very high deprivation, and very high population of young children as a percentage is clearly correlated with that higher deprivation, because you don't typically get to be over 75. We can look at ethnicity, and there was a comment earlier about how do we engage prophylactic solutions in a community. Well, actually getting the messaging right at a hyper-local level, and that will include making sure that we're communicating in culturally appropriate ways, but also when we look at education, skills and training, that our materials are appropriately worded so they're easy to understand. We have areas where there are digital deserts, so people aren't accessing digital technologies. So we may actually still be putting leaflets through people's letterboxes, because we know that typically they're not accessing emails, social media. So all of that information, we start to take that big data and get down to a hyper-local solution, or the ability to deliver hyper-local solutions. And in terms of could this apply to things like medical trials? Well, if you're looking for a population that's specifically got high levels of Black and Black British people in it, or Asian and Asian British, who have a higher prevalence of smoking or obesity, or you can set a persona against any of these characteristics, and we can show you where you are most likely to find those people in England, and hopefully as we progress across other geographies. So that's why we think we've got a place in supporting better efficacy in clinical trials, and part of that is to enable those people doing those trials to go to communities where they are most likely to see a broader section of demographic. So I've just put this in again because there was a comment earlier in a presentation about black mold. So I challenged myself to say, could I just quickly do something about that, because we work with a lot of housing associations and it's a real problem. So what I'm going to show you took me, because we've got these tools that we can deploy and just use the drop downs. This took 6.5 minutes to prepare the slide by dragging and dropping pictures in from our tool. This is energy efficiency, but so when you buy a house or sell a house in the UK, or rent a house, an inspection's done called an EPC inspection. You get a nice one-page certificate with some pretty colors on it. There's 96 data points in there that tell you what kind of windows there are, what kind of heating is the primary use, what the emissions are, what the CO2, whether it's insulated. So you can start to identify poor quality housing that, for example, might be prone to having mold. And we can actually start to identify where we've got high levels of privately rented houses, which are poor quality. Why is that important? Because when we start to look at where our children are in this footprint, we'll be able to isolate areas where we've got poor housing and high numbers of children. More than that, this is DWP data, benefit data. So we can see universal credit households which have any number of children in them. Again, all GDPR compliant, and this is where the layering of the data creates incredible insight. So we can start to see vulnerable families on low income in poor houses, which have a higher chance of having black mold. So where would we go? If we could just go to one, we could run the data on this and effectively give you a hit list of start here, then go there, then go there. So the ability to deploy things like the black mold solution at pace to maximum efficacy become very real. This is asthma sufferers, so we might be able to see where we've got high asthma and COPD prevalence versus poor quality housing. And I've just put over here now, so we can see this is the private rented. In that little footprint there are 106 privately rented houses. The current energy rating is 59, good is 30, poor is 70. So yeah, as I say, 6.5 minutes to put that together. But fundamentally, I mean, hopefully that just gives you a view of the incredible solutions, interventions that I've heard talked about today. There is a way of understanding how we could deploy them into populations which are aging fast, but we wouldn't typically associate with solutions aimed at aging populations. And that's me.
Sorry, you didn't hear that. Just somebody said, "Do you want a job?"
I started a business so that I didn't have to have a job. And actually, I wear a Fitbit, David, and mine says I should eat less, move more. My heart age and my physical age are, well, my heart age versus my physical age is terrible, because I run a small business. You know, there are 5 of us. Just for some context, there's 5 of us in the business. We did £500,000 across the NHS and pharma last year. We're going to double that the next 3 years. So no, thank you for the kind offer. We're keen to talk. We're keen to talk to partners that are working in America.
Adam, it was only in jest, but thank you. That was an amazing, amazing presentation. B, true to my heart and my seaboard, which I'd like to introduce you to. But are you, just out of curiosity, just to add a little bit more sort of texture, could you identify the relationship between black mold and medical assistance or litigation or other extended potential for black mold, and how that might be interpreted in an aging and or other population?
So the answer to that is no. However, what we do have ambition to do is to pull in clinical research papers. So when we're chat enabled, we will be able to say what's the highest where are the highest correlations of at-risk populations and poor housing quality, and based on the available research, what's the clinical impact of that on those people. At a simpler level, what we can identify is, because we hold prescribing data for primary care, is we can see if there's unwarranted variation in prescribing of things like inhalers and child inhalers in those geographies where the housing quality is poor and the vulnerability is high. So we can actually identify clinical harm, if you like, or clinical risk that's being managed in primary care that's directly correlated to poor quality housing.
That would be great to work with you and have that conversation offline at some stage, Adam, if it's approachable.
Please do. Yeah.
Okay.
Yeah. David, please feel free to. Yeah, please feel free to share the slides, David, and my contact details are on there. But thank you for the kind words. You know, it's quite an illustrious group of people to be involved with, and yeah, thank you.
I wouldn't call myself illustrious, just an opportunity.
I wasn't talking to you. I'm joking.
Adam, can you hear me?
Yes.
I've got a question on like, where are your main data sources? Is it this publicly available data that you're bringing into one data lake? And you mentioned like wanting to scale out, and like I know that one of the biggest engineering challenges is actually just getting those different data sources into a usable single format.
Yeah.
So how are you like bolting on different data sets?
So we used to be terrified about talking about where we get our data sets from, but the reality is 10 years of taking data that's published into the public domain by the English government initially has made us understand just how bloody awful it is and how uninteroperable it is. So creating the keys and the common currencies to make that talk to each other and overlay with each other is the magic sauce, if you like. But now, as we've become more proficient at that, there are still 40 odd Office for National Statistics data sets that we're yet to ingest, but we know we can do it. There's a list, I think we've got a list of 40 or 50 data sets we know we could ingest if a customer wants them. And then, as we say, as we move to the States, the NHS data that we have, Medicare, Medicaid have got that, but actually we'll sell it to you with far more granularity than we're allowed to use it in a GDPR compliant world in the UK. So the ability to replicate this product across countries, or as was pointed out to me the other day, if someone wanted a population health data set and tool that actually worked and they had nothing, please don't make it like the British government does, because that doesn't work. That's why we exist.
So if you, in the States, if you try and go the partnership route with like Medicare Advantage, they're a little bit like, they'll be quicker to adopt and look at you. There's a bit of a regulation kind of crisis at the moment.
Right.
I think around like two years. But the Medicare stuff, like they have so much insurance-backed data. I'm sure you'll be able to add, but like, yeah, you'd have to go like find some real good partners. But some of the Medicare Advantage plans, that's basically like the value-based healthcare system in the States.
Yeah,
they're a lot more willing to adopt new solutions and partner and kind of especially as companies.
What we do know is that in the UK health economy, the appetite to pump prime these preventative solutions doesn't exist. In an insurance-led, regardless of what we think about insurance-led health economies, an insurance mindset says that if you can show me how I can get upstream and prevent diabetes exacerbations, prevent COPD and asthma exacerbations, if it's less than the episode for that person to be admitted into a hospital, I'll put the money up front. No, I'm going to cash the check as an investment. So the insurance model gives us a return on investment landscape, which if we had in the UK, wouldn't be in the mess we're in. That is not to say, putting in privatized, but it's that return on investment mindset as opposed to a profit and loss one, which makes places like America and other insurance-based economies more able to adopt into innovations and more able to use data like ours to say, wow, that's an absolute no-brainer. The 10-year burn return on investment on that is 50 to 1. When can we start? We can start tomorrow, but go there first.
Yeah, there's a couple not this same but similar areas that have done very well by kind of initiating in the UK and then going US for to get the funding and to get that off the ground.
It's interesting because my background's in doing improvement work in the NHS, and I'd spent a while as a divisional director of medicine, ran an A&E department. But what we've built has come up out of our understanding of the UK health economy, so we had to do that first.
Adam, I'm Sandra Cowan, Future Care CEO, founder. We're working with Vitality. Well, we've got an introduction to Vitality. We've had a conversation with them. We're not ready to reapproach them, and we've also had a conversation with State Farm, which is the leading protection insurance company in the States. So there's lots of synergy that I can discuss with you.
Please do reach out. We're really keen to test the capability. Just how far can we go with this? It was the fact that it's turned into a business is great. The fact it could be a scalable, successful business is great. But our appetite is to find out what the limits of its capability are. That's what we're in it for now.
I'll happily debate that with you, with my colleagues.
Thank you.
I'm just gonna.
Okay, we just need to swap this over.
Charming one, but
Yeah,
nonetheless.
thank you very much. Thank you very much, Adam.